Hepatitis C can live in a human body for decades. While a patient feels perfectly healthy, the virus is quietly wearing down their liver cells. To stop that damage, doctors need definitive biological proof. That proof starts with finding these specific viral clusters in the bloodstream. Because time and resources are limited, the first step in almost every clinic is a lateral flow assay, commonly known as a rapid card test. A single drop of blood goes into the well, and within minutes, the patient gets results. When 2 lines appear on that card, the immediate reaction is usually panic. Patients assume those lines mean they have an active, destructive infection right now. But that card is actually just a smoke detector. It tells you there might be a fire, but it doesn't confirm if the flames are still burning. This creates a major bottleneck in medical care. You cannot prescribe heavy antiviral medication based on a rapid card alone. Protocols demand a secondary lab test to verify the threat. We are caught between 2 extremes: a plastic card that costs a few dollars and can be used anywhere, and a molecular lab procedure that requires expensive machinery and trained specialists. To understand why doctors insist on that expensive lab work, we have to evaluate these 2 tools on 3 criteria: what they actually detect, their accuracy timelines, and how they guide the treatment roadmap. That secondary lab work relies on the RT-PCR test, a laboratory technique that amplifies tiny amounts of genetic material so they can be easily measured. The clinical math is straightforward. Hepatitis C treatments are costly and carry side effects, requiring absolute molecular proof before a regimen begins. Rapid cards target HCV antibodies, the specific defense proteins the immune system builds to fight off the infection. This creates a critical clinical blind spot. If your immune system successfully fought off the virus years ago, those antibodies remain in your bloodstream as a permanent historical record. As a result, a perfectly healthy person with no active virus in their body will still test positive on a rapid card. It triggers a false alarm based on a past event. RT-PCR bypasses the immune system entirely. It searches directly for the virus's RNA, the actual genetic code that the virus uses to replicate itself. Instead of a simple yes or no, RT-PCR performs a specific count. It calculates exactly how many viral copies exist in 1 milliliter of blood, establishing the viral load. That viral load is measured in international units per milliliter, or IU per ml. If that number is above 0, it proves the virus is currently active and replicating inside the patient right now. The card shows the body's memory of the invader. The RT-PCR shows the invader itself. There is another severe limitation to screening cards called the window period. The window period is the time gap between when a person is first infected and when a test can actually detect that infection. Plotting weeks since exposure, the virus multiplies rapidly within 2 weeks. The immune system is slow, taking 8 to 12 weeks to generate antibodies for a rapid card. This dangerous false negative window means patients test negative and feel healthy while the virus spreads. This justifies the cost of RT-PCR for anyone with a high-risk exposure. The lab test can detect the viral RNA within days, closing that 10-week detection gap. When it comes to early detection, the rapid card is effectively blind. RT-PCR is the only reliable early warning system available. Once an active infection is confirmed and treatment begins, the clinical goal is exact: drive the viral load down until the RT-PCR machine can no longer find a single copy of the virus. The rapid card cannot monitor this progress. Because it only looks for the immune system's footprint, the card will stay positive every day of the treatment, and for years after the patient is completely cured. Doctors track recovery by running new RT-PCR tests at week 4 and week 12 of the medication cycle. They need to see the RNA numbers actively dropping to verify the drugs are destroying the virus. The ultimate target is SVR, or Sustained Virologic Response. SVR is a medical classification, meaning the virus remains undetectable in the blood long after the medication is finished, marking a permanent cure. A plastic card starts the patient's diagnostic journey, but only the molecular data from an RT-PCR can officially declare that the journey is over. The hepatitis C virus exists as 6 distinct genetic strains, known as genotypes. This genetic diversity determines the exact treatment plan. An antiviral pill engineered to eliminate genotype 1 might fail completely if the patient is infected with genotype 3. To prevent that, labs perform an HCV genotyping test. This acts as the biological blueprint, allowing the doctor to match the exact genetic strain to the specific drug designed to kill it. Patients often feel frustrated when doctors order this third round of testing, but skipping it risks putting them through months of toxic and useless therapy. Modern medicine has introduced pangenotypic drugs, which are medications designed to treat all strains of the virus. Even with these generalized drugs, knowing the genotype helps doctors predict exactly how long the treatment cycle needs to last. If the RT-PCR proves you have a fire, genotyping tells the doctor exactly which type of fuel is burning. This flowchart synthesizes the diagnostic roadmap. Step 1 is the rapid card, the initial signal of exposure. Step 2, the RT-PCR viral load, confirms the virus is actively replicating. The final step, genotyping, determines the exact formulation required for a cure. For patients, the instruction is clear. Do not accept a positive card result as your final diagnosis. Insist on molecular verification before making treatment decisions. For medical professionals, use the window period data to your advantage. If a high-risk patient tests negative on a screening card, calculate their exposure timeline to determine when an RT-PCR retest is clinically necessary. Navigating a hepatitis C diagnosis requires moving past the initial panic. Demanding exact biological data is the most important investment in a patient's health.